Well, thank you so much for coming here. This is the Health and Human Services Committee. Kateri Walsh is on her way. I just want to say this from the outset, as far as Bay State Medical is concerned. You are one of our largest employers in the city, if not the largest, and you're the most important, as far as I'm concerned. What you deliver to this community is astounding. And the amount of pressure you're under with the amount of people you have to see, it's astounding how you can be in medicine. Medicine is the best profession in the world. I want to call this meeting together because this is Cancer Awareness Month, Breast Cancer Awareness Month. And I wanted to get a good feel of where Bay State Medical is now for treatment and what you have for outsources. But before we start, can we just get everyone's name as we go around?
Bashir Saker, I'm a medical oncologist. Breast medical. Yeah.
And I'm Seth Kaufman. I'm a radiation oncologist with a focus on breast cancer.
Thank you, Seth.
And I'm Rawad Elias, Vice President, Medical Oncology, Medical Director of Oncology.
Holly Mason, Section Chief for Breast Surgery at Bay State.
I'm Kendall Hussain. I'm the Senior Director of Diversity, Equity, and Inclusion at Bay State.
Thank you.
I'm Tyann Henson. I'm a nurse first, and then I'm the Senior Vice President and Chief Diversity, Equity, Inclusion Officer.
I'm Hannah Marie Golden, Director of Community Relations and Community Benefits.
I'm Cindy Sherman Murphy. I'm one cancer survivor, and I'm also the founder of Each Moment We're Alive Cancer Support Systems.
Thank you. Dan?
I'm with her. Dan. Councilor Victor Davila from Forest Park.
If we can start, where are we? I look at the statistics. I think it's 1 out of 7 women get breast cancer or diagnosed with breast cancer during their lifetime. And I was kind of taken aback when I saw the numbers on Black and African American women have a 38% higher mortality rate than white women. And that caught my attention. That caught my attention. That caught my attention. And Helen Carlton is here. Hi, Helen.
Hello. Yes, hello, everyone. I just came out of a 1 o'clock meeting. What an impressive group of experts you have, Counselor. So thank you for the invitation.
You're the expert. Thank you, Helen. So I saw those numbers, and actually I saw that Black women also have the possibility of getting triple negative breast cancer, which is very, very dangerous if you don't get it in early stages. My wife is a survivor of breast cancer. She went through a year, pardon my emotions, she went through a year of chemo, a year of surgery, and a year of radiation. But she is, knock on wood, she is a survivor. But as we all know, there's no cure for cancer. It can come back at any time. So if somebody could address the issues that where Bay State is now for treating breast cancer, and any outreach we can give the community if they happen to need help.
I think I'll start kind of representing both surgery and radiology. So I think, for any patient, it's early intervention, and so it's early screening. And I think focusing on getting patients in for their mammograms on schedule. As many people know, there's been a lot of controversy over the last 20 years about when to start screening mammograms, and in general, all the societies couldn't agree. But actually, as more and more data is coming out, actually most of the societies are actually trending back to where we used to be, which is starting at 40. Again, the idea is if you catch cancer early, maybe we can catch it before you need all these extensive treatments. You need a lot of lymph nodes removed or mastectomies, those types of things. And, what you say is true about the African American population, definitely higher rates of triple negative cancer and, advanced cancer. But we have to go back and think about, let's find these patients early, identify them early, make sure that when they get their interventions, that they're right-sized for the disease process that we're seeing. Across the board with breast cancer treatment, it's a trend of what's called de-escalation, where we're trying to avoid treatments that aren't helpful, do the treatments that are, and a greater focus on quality of life. And some of the things are, we're really in fewer and fewer patients taking out a lot of lymph nodes. And in some patients, especially patients over the age of 70 with certain cancers, we don't take out any lymph nodes at all. And actually that's moving back to starting at 60. So that's great. You know, if it's not going to change, you know, your cancer care isn't going to benefit your survival, then we shouldn't be doing it. So I think from the surgery standpoint, we're getting better in terms of right-sizing things. I think it's focusing efforts on the radiology side, the screening imaging, identifying the high-risk patients. Maybe a mammogram isn't enough. Maybe they should get screening ultrasounds or MRIs, identifying those patients. I think in terms of disparities, though, we then get into the issue related to cost of care and what burdens our patients can withstand with the current insurance environment that we live in. I think that makes it a little bit more complex, especially in our high-risk patients.
Is that one of the reasons why the late diagnosis?
It can be, you know, we see, you know, mammography generally we do reasonably well with. I think especially with the Rays of Hope, you know, especially in October, and we see a huge influx of patients coming in for mammograms. I think the word is out. The risk identification, identifying patients at high risk, that's harder. A lot of the burden goes on the primary care community, which the primary care physicians are so overburdened with having to take care of everything else that doing good risk stratification is difficult. But I think also we see, unfortunately, a lot of fear of what breast cancer treatments, you know, are going to entail. And so we do see a fair amount of advanced breast cancer just because patients are fearful of what they're going to hear and what they're going to need to undergo.
Thank you, Councilor Santinello. Thank you for that explanation. I just have some quick questions. You were talking about, Councilor Santinello mentioned 38% higher mortality rate for minority women. I believe specifically for Afro-American women.
And Latino
And
and
Latinos.
Asian. Yes.
Would you be able to give me some, I guess, some social determinants as to what that is? Is it more congenital? Is it nutrition related? Why are these women 38% more likely to get breast cancer?
Mortality.
Mortality, thank you, mortality.
I mean, I don't know if Dr. Sacher has any thoughts, but certainly the triple negative cancers are more aggressive. And why do African-American women, are they more likely to get triple negative cancers? It's actually a racial heritage. And there is good research being done tracing this, you know, back, trying to figure out why. But, you know, and that is just based upon genetic makeup of the patient, not necessarily anything they did.
Yeah, I think so. But it's at least in part just genetics. There's a predisposition to developing triple negative breast cancer. But it also turns out that in African American women, those triple negative breast cancer don't seem to respond as well to chemotherapy as in other races. So it's multifactorial. Is there a little bit of discrepancy in screening also based on socioeconomic status? That's a bit different. I'm not. Okay. If I may, the word triple negative has been used a couple of times. Can you give us a quick overview of what triple negative is? So when you diagnose breast cancer, you classify it based on certain markers. So the pathologist looks at markers in the cancer cells, the estrogen receptor marker, progesterone receptor, and something called HER2. And so you can get all the combinations of positive and negative. So those are either positive or negative. You get all these different combinations. So when all three are negative, it's called a triple negative cancer. When the first two, the estrogen receptor, progesterone receptor, are positive, those tumors are hormone sensitive. So we have anti-hormone medicines that can help improve survival. When the HER2 is positive, we have targeted medicines towards the HER2, which makes also the treatment more effective. For the triple negative, you don't have those two treatment options. Your only treatments are chemotherapy and more recently, something called immunotherapy. but chemotherapy is the
Could you explain the immunotherapy?
immunotherapy.
Yeah.
Essentially, these are medications that release, so to speak, the immune system to be able to recognize the cancer as a problem to go after it. So cancers have a way of protecting themselves, making themselves invisible to immune system. And those medicines try to unmask the cancer so that the immune system can help go after the cancer cells. Does that help a little?
Yes, very much so. One of the statistics I just saw recently was that as far as African-American women, breast cancer now is past lung cancer for the amount of deaths that occur with breast cancer among African-American women. That happened in 2022. Only because less people are smoking now, those numbers are going down, but the breast cancer still is going up, and it's now past lung cancer for the #1 cause of death among African-American women.
Quick follow. Thank you. So thank you for that explanation, doctors. Now, we were talking about 38% mortality rate on African-American women. And what you guys were talking, I was thinking about immigrant community. What can you tell me, if anything, about our immigrant community here in the city of Springfield? How are the females doing, and what is based in, and to you, Commissioner Carlton, what are we doing as a city to specifically address female immigrants that are coming in from very remote parts of the world here, Bhutan, Nepal, you name it. Would you be able to give me a little bit of details on that, if anything? If anybody has?
I think the Bay State Health Centers do a good job at trying to get these patients kind of caught up with the screening, and the ability to have not only in-person interpreters, but we have the
Right.
virtual interpreters really has helped, because it used to be very difficult to communicate with patients. And now, we have interpreters at any point to
Right.
make sure that, we can try to overcome the language barrier. So I'm not sure if there are any other comments related to that, but the health centers work hard to
Right.
catch these patients and get them, at the same level of care of our other patients.
But I don't want to get too much into the minutia of this question, but are we seeing specifically to this subgroup of women, are we seeing a high mortality rate or a breast cancer rate? Because I know in my experience, I've seen some females with cervix cancer that never had pap smear done in their life, never had any kind of GYN care in their life. If you don't have an answer now, I would like to maybe, if anybody has any kind of data that we can look at, because it's a very real population is, our population here is growing rapidly, migrants community, which is, in my opinion, one of our strengths here in the city of Springfield, the diversity that we have in the city. So, did you want to say something?
I was just gonna say, from a perspective of that specific data, I don't have that at hand, but what I will say is, going back to the community health centers, there has been, over a period of our recent years, where we've had very specific focus on increasing breast cancer screening and really ensuring that there has been that outreach related to that. And back to some of the commentary, we just actually went through some health equity certifications, and it really spoke to the work around our language access, all of the many languages that we do see and treat within our 4 regions across that we do really speak to. I know that at some of our community health centers, we have specific clinics and areas that are focused on migrants that come farm populations as well. That we're really focused on ensuring that their needs are met, not only from a linguistic perspective, but also culturally, from a perspective of cultural congruent care. So we are looking very much at those milestones and not just looking at them from a perspective of primary care, but there's a specific piece where we're looking at our community health centers and goals related to that and our primary care centers, because we do realize there are some social determinants or social drivers of health that are relevant there.
If I may, I just want to conclude before I pass it over to Councilor Santinello. The words primary care has been used already repeatedly in this conversation. And I know that you guys put a great emphasis on primary care and have clinics. And for that, I want to say thank you. Because we all know that they're kind of on the front lines, primary care. And we all know that in this country, we have an issue with primary care physicians. They're not getting reimbursed appropriately. They're overworked. The burnout rate is pretty high. And God gracious, that they're in the trenches. They're in the trenches. And so, I do have a soft spot for primary care. And we need to do better as a country, for God's sakes. So that we can, before it gets to the experts, they can we detect it on time. So I did pick that up, and I thank you for the emphasis on primary care, which is so great. But Councilman.
Yeah, you had mentioned about fear or being scared. Cindy, maybe you can come in here. There's different phases when you get diagnosed, then you get treated, and then you're released, and then you're on your, a lot of people feel they're on their own. Could you just explain?
Yeah, so I'm Cindy Sheridan Murphy. I'm a survivor, and I am triple negative breast cancer. And, so just saying that. And so I think what is like, as I was saying earlier to you, is as doctors, they've done their job. You've done a great job. You've healed us. We're back. But then it's that going back to life of now, what do I do? Like I was not able to work as a dental hygienist anymore due to the lymphedema in my arm. But it's like, okay, reinvent yourself and think of your career you've done for 36 years. And you're like, I don't know what I'm going to do. I'm like that square peg trying to fit into that round hole. And I think that's where a lot of fear comes in too, is not only am I going to live, what's going to happen to me next, where's my 10 years going to be, but how am I going to survive and what am I going to do? And that's where each one we're alive that we found it was a lot of aftercare help. So the doctors are done, the primary doctors have done their job, US surgeons have done our jobs, but we help with that fear of that reoccurrence of knowing you're not alone. Like you get to talk to other people. And that's where we're really big on peer-to-peer, face-to-face. We do all through Zoom and that. So that you always have someone to talk to help with that fear. Because the fear is real. I know triple negative, this time it came out as melanoma. It's not triple negative this time, I got melanoma. But you're right, cancer will always be part of probably a survivor's life.
Thank you so much. I just want to touch upon real quickly AI, artificial intelligence. Where are we headed with that? And how could that be a tremendous factor for any kind of cancer, but breast cancer also, as far as mammograms, and you read all this stuff in the newspaper, on television or on the newspaper, where they now think they can diagnose it 4 or 5 years before it develops. Where are we with that? And who wants to tackle that?
I mean, I think we're seeing AI, enter into all aspects of medical care, certainly, in the development of treatments, in the interpretation of our testing, of the radiology, of the, pathology specimens, being able to be assessed that way. And we're not really sure where it's all gonna take us, I think. We're seeing, like in my field, in radiation oncology, AI is already being used to help when we design a radiation treatment plan. We have to draw out all the normal anatomy and tumors and everything. AI can do that in an instant, and we have to then check all of that being done. AI can be part of the planning process for the radiation and designing a treatment plan. So it can do all these things. At the moment, it's not doing it well enough. So we can't, of course, we need to oversee all of this stuff, but it's where this is going to go. I think it's going to go quick. I think we're going to see a lot of change in the next year plus, but it's a little hard to predict how it's going change all of what we're doing.
So how are you? How does Bay State stay on top of AI? How do they know what's coming, what's there? Well, do you have a department on that?
Well, that's a good question. I think in terms of the medical care aspect of it, you do have within the various disciplines of medicine, the means by which AI is enhancing those fields of medical care. In radiation, radiology, medical oncology, those specialties are, through the societies of those specialties, these things are being advanced, and that stuff is being, as it's being developed, is being brought in very rapidly to Bay State through the various practitioners. I don't know if anyone else has any.
So there are
Yeah.
pieces, as Dr. Kaufman said, there
Yeah.
are pieces that, each of us, when we notice in our field that is having an impact on here and it's established as something to use, we are moving it forward. There is an overall, AI is going to be integrated into every single aspect of cancer care and into the electronic medical record system. And that's a bigger, more resource in, requiring conversation, and that's going to take time. But, that's the future. We see AI also is going to take time in the medical field. We see sometimes the great news. Sometimes also there are not so great news about AI performance that doesn't get as much publicity. And when it comes with, cancer care, and when it comes with healthcare, you want to be very cautious about everything you're deploying.
Absolutely.
You don't want to say, okay, this is, I went into the AI and he told me, or the AI instance told me, this is the treatment, and you trust it. We're not at a point, and I don't know if we'll ever be at a point, maybe we will in 10 years.
Mhm.
But at this point, we still need to verify the information coming in and coming out.
Catering? This is Catering Walsh, one of the city councilors,
So I'm a little
a
late.
member of this committee.
Okay. So I'm just listening to AI. I kind of think that's a little scary. I think I'd much rather have personal input if I had cancer. So it's not going to replace doctors, I certainly hope.
No, I think we're hoping it's gonna help us and make us more efficient and kind of take some of that burnout factor that all doctors are going through now. But, from what we're seeing, I don't think it's gonna replace doctors. And initially, there was some talk about that, but now you see even the AI leaders, international leaders saying no.
Are you using it right now
Yeah.
in any capacity?
Yeah.
Sorry about that, I'm a little late.
I mean, in various ways, we're using it to enhance the work we do. It's not replacing us or replacing, personnel in the chain. But that's really the benefit. And I think it will be, like in every other field in the world, it's gonna be a valuable tool, but a tool.
I'd just add that, sorry, that where we're not using it, I'm a medical oncologist, by the way. So in decision making, so when we're speaking to people, we're not using AI to make decisions about treatment. It's not so far. How it happens in the future, short term, long term, it's hard to tell.
I think one of the important pieces with that is, being able to assess what the goals of the patient and what the fears of the patient are, and balancing and figuring out how to wend your way through a treatment plan that can address those issues. And we have patients with comorbidities, medical issues, and we have to balance our treatments with that. So sometimes I don't do, the standard of care surgery because someone has a bad heart and wouldn't be able to really safely recover from it. So I'm going to do a different surgery so that the patient can, do well afterwards, and things like that, chemotherapy, decisions related to that. And also, patients' willingness to undergo these treatments. And I'm not sure that AI, is going to do that well, at least at this point.
Awesome.
Thank you, Councilor Stillo. I have two quick follow-ups, but first regarding AI, I have to say that it gives me great pleasure to hear that it appears that you guys are being, going to use the word cautious here with AI, because even in 10, 20 years, I still would like to see some sort of human judgment involved in this. I'm not exactly sure that I want to put my faith in the hands of a machine. I see it most as a tool to help you with the diagnosis and the treatment that remains to be seen, I guess, so I'm glad to see that it appears to me that you guys are being very cautious with this, so thank you. I want to address 2 quick points. I want to talk a little bit, if I may, from everybody. Nutrition. We're talking about cancer, we know nutrition is also important. In relations to, because we started talking, Councilor Walsh, about African American women having 38% mortality rate from breast cancer
Definitely need to
as
address
compared
that.
to other samples. We do know that we have food deserts here in the city, and it's something that has been addressed before. To eat more greens, more green vegetables, more fruits, exercise, lower your stress levels, but specifically with the food intake. Does anybody have any comment or data that they can share with us about specifically how are the I'm gonna use the word minority, even though I hate it, the minority female population doing in terms of nutrition as it relates to cancer care as compared to other groups? Do we have any kind of data on that? No.
Helen?
I'm sorry, was that a question for me?
I don't know if you heard the question.
Helen,
Commissioner, what I was asking was.
No, I heard your question, I just didn't hear it. I heard your question around nutrition, which is an excellent question. I guess the question for me was, were you looking for me to respond to that?
Anybody can
Yeah.
jump in. I'm just trying to, because I know that, I believe what Dr. Kaufman said, somebody said a little while ago, this is a multi-layer issue approach. And so I'm just right now talking about nutrition. And I know we have spoken in the past, Commissioner, about the food deserts that we have here in the city, and even how we as a city can help to complement and create the conditions for more appropriate markets here in the city. So that's my question.
I think in general, when it comes to cancer and cancer, when it comes to cancer and cancer incidence in general, we know diet plays a factor.
Mhm.
And we know that unfortunately, part of the increasing cancer incidence is the diet that's changing and access to healthy food. It's, access to healthy food is challenged, right? We all know that going and buying fast food is probably much cheaper than being able to go and have a healthy meal.
Mhm.
And so that's a national challenge, and that's maybe also an international challenge as people are relying less and less on cooking at home and making something healthy, but rather going up to the restaurant next door or the fast food chain next door and picking up something. It needs, I think a big part of it is gonna revolve around education. And there's some of that, but some of it is gonna be thinking together, how can we make sure that people have awareness and access to the healthy nutrition? You talked about the triple, the multiple layers, and I think the one thing that is also important to highlight with that is that there are community factors, but there are also medical factors, which is unfortunately a lot of our research comes from studies and trials that are done on patient populations that do not necessarily mirror the patient population we see in the clinic, particularly in a town like us. So that's why, for example, as Dr. Sucker mentioned, the triple negatives that we are seeing will not have the same response to treatment as the ones in the clinical trials. And that's a big problem. And the FDA has tried to work on it a little bit, but that's another piece that we need to make sure that the trials and that we are using to guide our treatment decisions include more of the patients we are seeing in the clinic.
I would say that I find this conversation fascinating, but are we doing, or is Bay State doing anything specific to our population? Any kind of, I'm gonna use the word trial or investigation that is specifically addressing our population?
Yeah, so I think, so one of the, and I'm gonna let Dr. Mason and Dr. Sucker talk, but I think one of the most important things we are doing is bringing clinical trials to our community.
Mhm.
Because that's how you are able to make sure that our community and patients who belong in our community are represented in these clinical trials, and then we can get data to guide their decision rather than, I'm not gonna patients east of the state or in New York City, but rather our true patient. But I think there has been a lot of work that has been done with the Rays of Hope and the PLVI, Pioneer Valley
Mhm.
Life Science Institute, and Dr. Sucker also recently started a new clinical trial at Bay State. So I think you know more about the Pioneer Valley work.
Yeah, through Rays of Hope, there is a research process where as patients come in to see the breast surgeons, they can enroll in donating, if they have breast cancer, some of their breast tissue, and it gets banked and their information to supply it for future research. And it's been supported by Rays of Hope, and they're, I think at what, 1,500, 1,500 patients so far have provided this. And so you think about, that's our population. So as, the lab researchers at Pioneer Valley Life Sciences Institute, UMass, if they want to, if they have an idea for research, they could actually, go through our research board, the IRB, and see if they could access the tissue. So I think that's the kind of things that need to happen here.
Thank you so much. I have one last question before we move on. Earlier in the conversation, we talked about the cost of care. Can you educate me at least as to some of the most common challenges that women face when it comes to cost of care? Now, correct me if I'm mistaken, but my educated guess is that at least a basic mammogram is covered in all insurances, right? Is that correct, Maria? No,
Sure.
Okay.
Sure.
A screening mammogram.
Screening.
Yeah, okay.
But not all the same
I was
treatment.
like, Jesus. So what are some, 'cause you did, I believe it was you actually.
Yeah.
if I'm not mistaken. Can you tell me, or educate me as to what are some of those cost of care challenges that most women face?
There's different parts to it. So there's the cost of our testing. So you're correct, screening mammograms are covered, but once you get into the diagnostic mammograms, ultrasounds, MRIs, they may be covered, but there's out-of-pocket expenses, the co-pays, deductibles, and co-insurances, and then you get into your other treatments. There's also the impact of being out of work.
Mhm.
And in different, work situations will have support or no support. Also, you talk about our young women and childcare expenses and so there's all sorts of different aspects of cost of care. And, we hear not infrequently from patients that, they want to do whatever it takes to get through this, but they don't know how they can afford it. And even though we're, giving, recommending the standard of care that will be covered by insurance, they still have, a difficulty affording that standard of care.
A difficulty of.
Affording that standard of care.
affording.
And that's where the uninsured and underinsured discussion comes really to light in this perspective, because you are talking about that population that may be working, but right in that cusp of being able to making those choices around.
And those are life and death choices.
Yeah,
Right.
That's what we're talking
absolutely. Yes.
Does the state help out with that gap?
So, I mean, there are programs, I know, Medicaid and other insurance coverage, but there are certain thresholds, of course, that you have to meet regarding the federal poverty level guidelines, and whether or not you meet those and your family size. And
It's kind of
there
a
are
cliff
many,
effect then, right?
yes, exactly. And so there are many families that earn too much to maybe receive Medicaid, but not enough to really be able to, when you have to pay for the cost of insurance going through either one of the insurances that you might get through the choice of our state and or other aspects of selecting a health insurance plan that will provide the coverage that you need. So it's sort of one of those pieces of just difficulty. And I know that we as an organization have financial counselors and others that really try to work, probably definitely ones that are committed to the oncology cancer center that work with your patients specifically, but it is the reality.
If I may, I'm sorry, so specifically talking about cost of care and health insurance, I believe I saw recently that at least here in Massachusetts, the health connector is expected to almost double. If I'm not mistaken. Excuse me, specifically to go Obamacare, they specifically to double. And I know here in the city of Springfield, if I'm not mistaken, Councilor, health insurance is gonna go approximately 9–10%. That's quite a chunk. Are we specifically with cancer care drugs, are we expecting, if you guys know, an increase on these medications or increasing out of pocket? Can anybody speak to that?
I can tell you, they are extremely expensive. I don't know if there will be, how this will affect the community.
It's a very, the cancer,
Yeah, so.
the drug pricing is very complicated.
Uh-huh.
There was some question about potential tariffs on the drugs, and it's not clear how that is gonna affect the drug pricing or not when it comes down to the patient. It's very complex, I would say. So I don't know if anyone has a clear idea about that at this point.
Gotcha. Thank you.
I think some of the new guidelines also around recertification, particularly for Medicaid and other aspects that come into play, will have a potential impact to the patient recertification or to the organizations. Also, as we're providing level of care. So there's a lot of things to take into consideration as we're thinking about cost of care overall.
Cindy?
I also see coming from the survivor side is the cost of care. You're really in a fast-paced motion as you're diagnosed like with triple negative. You've got to get some answers done. And I know my oncologist, she was fantastic, but it's like, but hurry up. Like, you want a second opinion, but you can't dabble too long. So waiting to get that health insurance or maybe getting the health connector, that you don't always have a lot of time to get all those forms and getting that in. So that can be tough, like for you guys, for us, saying like, how do I get my treatments? I can't afford it, but I can't get anywhere either. And the second thing I see is a lot is that I hear in the groups is the generic drugs like the aromatase inhibitors, the generic ones, a lot of people have adverse effects to one generic one versus another one. But I don't know how do you manage that? Because I might be on, say, tamoxifen, but then I have the generic one, and this one's giving me so much aches and pains and I can't function. I get it refilled and I'm okay because it was a different.
Yeah.
You guys probably have no control.
No, see, I mean, we don't
But you
have
must
to,
hear
right?
about
It's,
it.
I mean, it's mostly managed by the benefit manager and the insurance company, and that's not something we have. But we do hear that from our patients sometimes, yeah.
Yeah, we hear it a lot.
Peter?
I'm sorry you're going through all that.
I'm done.
Oh, good.
I'm done. I don't want to visit them. On the other side, I'm on the survivor side. No, thank you.
I just wanted to put in a plug for Raise a Hope. It is October 19th.
Yep.
And one of their claims to fame is that all the money they raise stays in the local area. So that what you're talking about is probably a direct benefit of all of us supporting Raise a Hope. And it's over 30 years, correct? Yeah, we've been doing it.
Helen, one last thing. Is there any way that we can get a public service announcement out as far as Black females that have that mortality and they should go get tested, or they should go through a mammogram or get screened if they're suspicious of something, or they should go through that process anyway? Can we get some kind of a public notice out, a public disclosure through your department?
So thank you, Councilor Santinella. First of all, let me start out by thanking the team at Bay State Health. It has been an amazing partnership. Our 330 Health Center does not have a gynecologist on staff, and so I and our team is constantly referring to Brightwood Mason Square and Caring Health Center as well. So let me just start with the thank you for receiving the patients that we send to you. We also know there are waiting lists at health centers. The provider shortage is real, and it is real for those of us who are working with vulnerable and underserved populations to make sure they have access to health care. So, Counselor, we are in the month of October. We will be on our website highlighting women and their messages who have had breast cancer or who are recovering. And so our outreach will be focused on using the faces of individuals that we know who have gone through the experience. That will happen. That's a part of our outreach to say early detection saves lives. We want to make sure that we are absolutely looking at our healthcare systems that we have and making sure women can access them. You talked about food, so we also think about built environment. We think about nutrition, and we think about our social and community systems. So those are all the places that this department is really entrenched in and trying to get the message out about early detection, particularly for Black and Latinas, African Americans, because we know those rates for both of those groups are higher than the rates for white women. And so while we talk about this, we are intentional about who we reach out to. So we are doing that outreach, Counselor. I want to stop and thank Dr. Henson for her work, because whenever I call and I need some assistance in terms of being able to manipulate the systems and make sure there's access, Tyon, Dr. Henson, you have always been there. So I just want to just shout you out and say thank you for your support.
Thank you, Helen.
So nice to hear.
Yes. And I just want to reiterate what I said at the beginning of the meeting. You can't believe how thankful I am for Bay State Medical and what you do, and continue what you're doing. And I know you're busy, so you got to get back to work. But thank you so much for coming. You've really educated us and gave us a lot of information.
Yes, absolutely.
Yeah, thank you.
Oh my goodness, thank you.
What did you hear?
Thank you, Commissioner Harris, for all of your leadership in this space. We certainly appreciate in partnership.
It's a good job.
Thank you so much.
Thank you. Have a good evening. Take care.